Well, good morning, everyone. It's Eileen Bird, and I want to say good morning and welcome. As I said, Eileen Bird, I am the Executive Director here at 2Life, and you are entered into the discussion that, actually a very interesting discussion that we're going to have this morning as part of our Women's Health Conference series. Women's Health Conference series has moved to a virtual format this year. This is the second presentation in a series of 4 topics that we will be covering. And so we will be recording this session and make it available for playback. As you can, if you did miss the first session with Lily Shockney, that is on our website. You can find a link to it. And so today, we will be addressing the topic of trauma, and we will be joined by Dr. Cheryl Hysjulien. And so I'm sure you'll agree with me that nurturing our mental health is a critical component of living the very best lives that we can. Dr. Hysjulien will present on the stress and trauma of a breast cancer diagnosis, the sympathetic nervous system response, and about post-traumatic growth. And yes, you heard me right, I said growth, and mind-body tools for mitigating stress and trauma around a breast cancer diagnosis and treatment. The formal presentation, and there will be some slides for today's presentation, will be followed by some questions and answers. So I'm going to encourage you to put your questions into the Q&A box that is at the bottom of your screen. If you can't see that now, you can navigate your mouse down to the bottom of the screen, and you should have some icons available to you, including chat. If you can't find the Q&A, certainly go to the chat. And so during Dr. Hysjulien's presentation, I will be monitoring those questions, and we will get to them and address the questions after her formal remarks. And so with that, I'm going to get into our introduction. And I see Dr. Hysjulien is on, and she'll be getting her video going in just a moment. So Dr. Hysjulien is a registered nurse and licensed clinical psychologist at the Sanford Roger Maris Cancer Center, in North Dakota, specializing in health psychology with further specialization in psycho-oncology. She has worked in healthcare for over 40 years, initially being trained as a registered nurse, then becoming a clinical psychologist. She trained in mind-body-based medicine approaches at Herbert Benson's Mind-Body Institute at Harvard Medical School, and has continued to train in mind-body integrative modalities for their use in health psychology. Dr. Hysjulien has spent her 40-year medical career as a champion of holistic integrative approaches for patients and trained medical staff about integrative healthcare. She's practiced in a wide range of health psychology areas, including eating, cardiovascular, neurological, genetic, and other medical disorders. Her passion, however, lies in her work with oncology patients and teams. So Dr. Hysjulien, I see you right there. Welcome, welcome, welcome from North Dakota. Glad you're with us.
Thank you. It's great to be here. Like Eileen said, I am a health psychologist and a nurse. I've worked in the area of cancer for over 20 years or so. So actually, I had not heard a lot about this organization before I got contacted to talk, but I'm really impressed and excited to be part of this series. So, thinking on the way here about what I would say at the beginning, because usually I try to crack a joke to help me as much as to entertain you. And so I thought I would start with what my sisters and I were talking about this weekend, and that's that we are really, really super funny, at least to ourselves. So hopefully I'll make this a little bit entertaining. It's very hard for me to do a format like this. My integrative specialist is beside me, and she's very talented at doing Zoom. We do a lot of Zoom stuff, but it is a stretch for me to do it because I can't interact with people. But hopefully in the end, I will at least be able to interact with your questions and your voice. So, all right. And now I'm able to do this, and we're going to go here, and we're going to go to my slideshow. Okay. There. So you can see both me, hopefully, and this slideshow, hopefully. Okay. Thank you, my peoples. It's good to have supportive people surrounding you. So back to what I was saying, I really do like interacting with people. I like to be able to see your face, see you respond to me, but I'll kind of pretend, and I've sort of gotten better and even more used to doing this. So let's move on. We're going to talk about PTSD, post-traumatic stress disorder, and breast cancer. I'm going to also briefly mention acute stress disorder, which can occur with people diagnosed with breast cancer. And then I'm also going to do justice to a condition called post-traumatic growth and how that might be encouraged or fostered when you're going through breast cancer. So let's move on. Let's just start. Sometimes when I just get a start, I do better. So got another little glitch in that this little thing is in my slides. So I need to move that there. Good. So PTSD is a psychiatric disorder that occurs in people who've experienced or witnessed traumatic events, such as natural disaster, accidents, terrorist acts, combat, rape, or those people who have been threatened with death, sexual violence, or a serious injury, kind of a definition by the American Psychiatric Association. About 3.5% of people suffer from PTSD in any given year, and about 9% of us will develop PTSD during the course of our lifetime. Women are twice as likely to develop PTSD than men, and US Latinos, American Indians, and African Americans are disproportionately represented in the number of people diagnosed with PTSD. When we talk about the Diagnostic Statistical Manual, that's what the DSM is, the book. This is a little version of it that we use in psychology and psychiatry to diagnose people with conditions. So the criteria and definition are spelled out specifically so that in order to be actually diagnosed with PTSD, you have to have so many of these, but there are lots and lots of people with cancer who also have some of these and not all of them. But let's go through the definition. It's the exposure to actual or threatened death, serious injury, or a sexual violation. So that exposure has to result from one or more of the following scenarios in the person. So they have to directly experience the traumatic event. They can be a witness or in person to the events, but they occurred in another person. They might learn of the traumatic event or events as they occurred to a close family member or a close friend. And in cases of actual or threatened death of a family member or friend, the events must have been violent, not just like a natural passing quietly of someone. They had to have been violent or accidental. Experiencing repeated or extreme exposure to aversive details of traumatic events. This is something like when first responders or people who collect remains or police officers, and they're exposed over and over and over to the details of traumatic event, maybe in the form of pictures or media. It's not through like media like you and I would see on the television or news. It's actually as a part of the duties of their job. See, this is where I want to look at your faces and say, yes, are you bored or are you guys doing okay? But I'll move on. So that's a definition of the event that had to occur to be diagnosed with PTSD. But then there's 4 categories of symptoms that occur. And those symptoms tend to be of a nature that are in these 4 categories, such as intrusion. So intrusion categories are when you have repeated thoughts or memories or dreams or even flashbacks of a traumatic event. And I'll talk about some of these more in detail when we talk about breast cancer specifically. The flashbacks can sometimes be so real that people feel as if they're reliving the traumatic event or seeing it right before their eyes. And I've had many patients like recounting certain aspects of their diagnosis or re-diagnosis where you can see their eyes are kind of drifted away and telling me about it, but almost as if they were right there experiencing it. A second category of symptoms is avoidance symptoms. So people avoid reminders of the traumatic event. They avoid people, places, activities, objects, situations that might trigger any memories involved in that. They might try to avoid thinking about it, just like, oh, I can't think about that. I don't want to go there. They might resist talking about what happened or how they feel about it. So that's a second category of symptoms of PTSD, those of avoidance. A third is alterations in cognition and mood. So an inability to remember important aspects of the traumatic event, negative thoughts, feelings leading to ongoing distorted beliefs like no one can be trusted, I can't believe that happened, or personalizing it like I'm bad or I did something wrong to cause that. Distorted thoughts about the cause or consequences of the event leading to wrongly blaming self or others. In oncology, I'll give you more examples later, but that often is a result of, I had this pain for a long time, I went to the doctor and people missed it, people missed it, people missed it. So other alterations in cognition and mood involved ongoing fear, horror, anger, guilt, shame, decreased interest in activities that used to otherwise be very pleasurable and enjoyable, feeling sort of detached and estranged from other people. Even when you're around them, you might put yourself in that position, but you don't feel connected with people, or being unable to experience any positive emotions like joy, happiness, or satisfaction. And then the fourth category of symptoms of PTSD include arousal and reactivity. And those might look like irritability, like angry outbursts, sometimes behaving recklessly or in really self-destructive ways, being overly watchful or hypervigilant of your surroundings, or being really suspicious, being easily startled, and having difficulty concentrating and sleeping. Okay. PTSD lasts longer than a month. It causes significant distress or impairment in functioning, and it's not attributed to a substance. Like some of these things can be caused by mind-altering drugs or a medical condition. PTSD can also be delayed. You can have an onset of symptoms far longer than a month, maybe 6 months or even more. Okay, so let me go back a second. So that's PTSD, the kind of definition, symptomatology that goes along with it. I could bore you with extensive details of the other ways that things are diagnosed, but I just want to give you the general gist of what post-traumatic stress disorder is. You can imagine that by definition, you all have been faced with something that's life-threatening. So the criteria for having it with a cancer diagnosis is certainly there. Let me just mention acute stress disorder, and I'll tell you why in a second. It's like PTSD, similar events that are defined and similar reaction to the events. Those symptoms in those 4 categories are very similar. And the difference is the symptoms usually last from about 3 days to a month. They still cause significant distress and impairment in functioning. They still are not attributed to any effects of substance or a medical condition. And here's the kicker. About 50% of those people with acute stress disorder might go on to develop PTSD. And that's something I want to see if we can help people avoid, okay? So PTSD and breast cancer, as you probably all know, but I'll review just briefly a couple of things as it relates to trauma. So PTSD or breast cancer is the most frequently diagnosed cancer in women. And there's lots of new treatments, some of which I can't even keep up with as someone working in the field. So women are living longer, even with late stage disease. It still accounts for about 14% of the death by cancers in women, and cancer that accounts for the highest number of deaths in that grouping of 20 to 59-year-old women. A diagnosis of a potentially life-threatening illness, and it is a major traumatic event in people's lives. PTSD in breast cancer patient is associated with poor treatment outcomes, less treatment adherence, and increased unhealthy behaviors, and it's even related to suicide. So it's critically important. I know a lot of you are survivors, so I want you to pay attention from that aspect. Whether you're recently diagnosed, going through treatment, or living with cancer, just paying attention to these things and sort of doing a systems check within yourself to make sure that you are getting help if you need to, because it's not a good thing to let go. And then for people who might be helping people with cancer, whether you're nurses or therapists or social workers, case management, whoever you are, sort of having an increased awareness that this is something that really can happen. So cancer in itself can be traumatic, but when you think about women diagnosed with breast cancer, number one, it's the most frequently diagnosed, so people worry about getting diagnosed with it. And people are living longer and longer with it, so addressing trauma and its impact on overall health is really important. And then those scary facts, 14% of the deaths by cancer are still related to breast cancer, and the largest number of deaths in that 20 to 59-year-old age. I think I have covered that sufficiently. The prevalence of PTSD in breast cancer really varies depending on the research. Anywhere from 9.6 to 35% of the people diagnosed with breast cancer develop PTSD. While 9.6, that's still relatively high, and 35% is very high. But the other thing is, even though you can't concretely be diagnosed with PTSD or acute stress disorder, it is really imperative that you recognize the symptoms, because even though you might not have the number of symptoms needed to be diagnosed, you might have just one shy of that and still be struggling significantly, okay? Some of the risk factors for developing PTSD in breast cancer patients are being younger. And remember that younger are high risks and scary diagnosis, and that people really get anxious. It's different than if you're 80 years old and diagnosed with breast cancer. You're still in that part of your life that is even more, maybe even more traumatic, because it might affect things such as having children. Non-Caucasian, like I talked about, those numbers hold up with Latino Americans, Native Americans, and African Americans being higher representation. Recently completed treatment, and this is true for a lot of things, interestingly, like I'll see people at the end of treatment that go through our survivorship clinic, and then their anxiety gets peaked for a couple of different reasons: fear of cancer reoccurrence, fear of not being watched so closely, and separation from their treatment team. PTSD or other mental health issues that existed prior to the diagnosis of breast cancer are risk factors. People with overall really high levels of stress are more at risk. People that use avoidance as one of their main coping skills, they would be much more apt to develop those avoidance symptoms with PTSD. And they don't have a lot of skills for dealing with traumatic things in their life. People of lower income, people of lower education, and people who are single. And we'll talk a little bit more about some of those as they relate to protective factors as well. So a strong social support system. Oh, I want to stop because I just saw the chat button up there. I am not monitoring the chats. Eileen Bird is monitoring chat, so please keep putting your questions in there. We'll try to answer questions at the end, but we'll also try to combine questions so we answer as many as possible. But I'm not keeping an eye on that chat box in case you were wondering. Okay, anyway, protective factors so that you don't develop PTSD are strong social support systems. People, I think this is really critically important, people who are well informed about their cancer, about its treatment, and particularly about the stage. So those three things are extremely important, as well as a really good relationship with your healthcare team. So they're critically important in your protective factors from developing trauma-related symptoms. It was really reinforcing as I did the lit search again on this subject that we developed this program called Integrative Essentials pre-treatment, and it's something that we can use with all cancer patients. There's a stress management component of it, but then there is specific tracks and practices of relaxation, mindfulness, imagery, and hypnotic strategies to deal with the impact in a positive way. So imagining the outcome, knowing about your cancer is reviewed, and then we really emphasize in that program having a positive relation, a trusting relation with your healthcare team, because it's so critically important. Okay, now I just wanted to talk and give you some examples of PTSD in breast cancer patients. I gave you the global kind of general ones, but like I said, I first got involved in working with breast cancer patients, I think right about 1997 or 98. I took some nurses training in integrative nursing, even though I was a psychologist already. And that was a 2-year program where we met with people and practice. And along that way, I met what is now would be called a nurse navigator for the breast cancer team in St. Cloud, Minnesota. And we developed some programming around this too. So I just know that trauma, even if it's not diagnosed with PTSD or this life event, is significant for breast cancer patients. One of the kind of alarming or scariest things, if you experience or if other people see it, is flashbacks. And again, flashbacks are those recurring memories or feeling as if you were right in that position where the trauma first occurred. Now, that could be with the diagnosis, or it could be with treatment aspects along the way. For example, I've had people who have had very significant reactions to chemotherapy, and they have the reaction. And in our center, when you have a significant reaction to chemotherapy, a lot of people are involved, and the room becomes very small and full of people, and the patient's kind of sometimes a little altered, and they are very scared. And so there'll be times when they're then recounting that experience to me because they're scared to go back to do chemotherapy, where they're just saying they say, "Oh, my heart is beating really fast right now." And then the nurse came in and she said this, and then all of a sudden there were people all over the place, and she feels as if that same thing was happening to her right in that moment in time. Hypervigilance is this being on the lookout, and that might be more. You might be hypervigilant about a body. So if you had maybe some women will experience breast pain, and so they're hypervigilant about that. People might be fearful of reoccurrence of cancer in bones, so they might be vigilant. And this is a tricky thing because your doctors want you to be vigilant, but you're not supposed to be too stressed all at the same time, right? Nightmares can happen as a result, and they wake people up and are very frightening. And again, that arousal happens, which I'll talk about a little bit more. Difficulty falling asleep, staying asleep are also symptoms of PTSD. Being startled, it would be like if someone enters a room, you'd be normally surprised, but in a startle reflex, someone would enter the room and you'd be, oh my gosh. And again, we'll talk a little bit about why that happens. Some self-destructive behavior, oftentimes a little excessive drinking, sometimes sexually acting out, driving recklessly, difficulty concentrating, attending. Some of these things, depending on where you are in treatment, might be attributed to your treatment itself, but it can be just a result of trauma and a symptom of PTSD. Irritability, angry outbursts, aggressiveness, easily frustrated by things, that's very common. And then an interesting, overwhelming guilt and shame about things. I need to take a break from me for a second. One time I was in graduate school practicing a speech in front of my children who were like little, and my daughter kept going like this, she kept going like this, and I got like, finally I said, Kate, what's going on? She goes, Mom, you're doing that talk and you got like white foamy stuff right in the corners of your mouth. So sometimes I take a break to make sure that that's not happening. Speaking of PTSD, right? So a lot of these, moving on, sorry, remember I told you I was funny, but well, not everybody appreciates my humor. Anyway, these symptoms of PTSD are a result of a sympathetic and nervous system arousal. My guess is, if I had a show of hands, how many of you, when you can remember exactly what happened when you were first diagnosed with breast cancer? So many people will remember those moments and the details of their moments. And the sympathetic or stress nervous system arousal happens when you're faced with something really traumatic. Most people that I deal with cancer, even without a really bad diagnosis, not that breast cancer isn't a bad diagnosis, but maybe you're diagnosed with stage 4 or a very aggressive form of cancer. Most people still have thoughts about death that come through their brain. They do. Like, oh my gosh, I could die from this, especially initially when they don't know the exact details of their cancer and or the treatment plan. So that sympathetic nervous system gets aroused and all kinds of not so good things happen as a result of that. It's our fight or flight nervous system. It was made to respond when we have a actual threat to our physical well-being. So a lot of these things are a result of that arousal of the sympathetic nervous system. So what happens is there's increased heart rate, increased blood pressure, increased respiratory rate. Your brain works differently because you want to respond acutely to what the threat is. The muscles are set to flee, and so there might be queasiness and stomach problems. The epinephrine speed shoots up and cortisol levels go up. So those are all just physiological reactions to the sympathetic nervous system, which is a normal response when you are told you have breast cancer, or a normal response when you go through certain aspects of the treatment. The problem with that is, while it's a normal response, having that throughout the course of your treatment can actually work against you in terms of healing. And that's where I want people to say, even if you don't have a full-blown diagnosis of PTSD, if these things are happening, you want to address them so you can optimize your own recovery and your own quality of life and well-being. Okay, so let's talk a little bit about treatment, which addresses those things. It's extremely important to get treatment as soon as possible. I don't know all the resources. What I do know from looking at this organization is that it's a good place to have find resources. So you all are together for a common purpose, and there's lots of information that can be shared about who can help, when, and where. It's a multimodal approach. Many aspects get brought in, and really remember those underlying risk factors. Those really need to be addressed as well. So if you've had long-standing major depression, or schizoaffective disorder, or substance abuse problems, you'd really want to concretely address those during your course of getting help for PTSD. Initially, a really crisis intervention model can really be helpful. It's just really normalizing the response, facilitating adjustment to the response, giving some tools to help people. But the bulk of what I do is predominantly based in mind-body medicine and cognitive behavioral or dialectical behavioral therapy. And so really what you're trying to do is help people understand the symptoms. So I would give them a little mini lecture about, this is why you are experiencing what you are experiencing at this time in your life, and just understanding and normalizing it. I can't believe how helpful that can be. Like, oh, well, so this is normal. A lot of people experience this. There is help. There are very, very usable, doable tools that I can get help with. So you teach people effective stress management techniques. First and foremost, I teach people that the stress nervous system has been activated, and one of the best ways of bringing your stress down is by activating your relaxation or parasympathetic nervous system. They're on a counterbalance system. I can't take, you've been diagnosed with cancer, here's your treatment, you're in the middle of treatment, or you're dealing with fears of cancer reoccurrence out of your life. That makes your stress level go high. But I can help people learn relaxation and imagery and breath work and hypnotic strategies. And when those happen, our relaxation parasympathetic nervous system goes up, and this has to go down. Okay, so but I use biofeedback as well as mindfulness too. We'll talk about a little bit of those. I got ahead of myself. So the other thing we do is we do restructuring of cognitions. So cognitive restructuring is when you take a look at your brain, how you are thinking, what you are thinking in a circumstance, and then you look at what the result of that is. So I'm thinking, oh my gosh, I'm not going to be able to do these things in my life. I'm afraid I will die. What if I call it the what if flight terror? What if this happens? What if that happens? What if the other thing happens? Those patterns of thinking will definitely lead to significant distress, either fear or sadness. And in general, they're not helpful, and they're not particularly rational. So we work on, if you are thinking these things, then you might have a different result. So take, what if I die from cancer? Well, I'm not dying from cancer because I'm alive and thinking still. So at this moment in time, I am not, and I'm going to take what comes every step of the way and not try to keep myself reined in about what's out there. And I might not never have to deal with that. So in my language, we go from what if this happens to if that happens, then I will deal with it. And if you can change your thinking, because we just don't think the way we think, we learn to think the way we think. And if you can change that thinking, then you will have a different emotional and psychological outcome. It also will impact behaviors too. So if you think, I'm not sure what will happen 10 years from now, but what I know right now is that if I exercise and eat healthy, then I will have a better outcome. I will have a positive influence on the outcome. Okay. So that's restructuring cognitions. I'm going to go to mindfulness, which is on the next slide, just because it fits a little better here. So in the old days, I did much more cognitive restructuring work with patients, altering the way people think. But you all have taught me, and then research has panned out, the fact that mindfulness approaches can sometimes be as helpful, if not more helpful. And they still elicit that relaxation, calming part of you. But they deal with thinking by just saying thinking is thinking. So mindfulness is awareness that emerges through paying attention on purpose in the present moment without judgment. So when you think about it, if you can break down this moment and this moment and this moment, then before didn't happen and what's coming next didn't happen either. You just have this moment in time. So you don't try to change your thinking. You just give yourself some space between you and your thinking, or you let your thinking go. It's not right or wrong to think what you think. But if you say, oh my gosh, what if I have a reoccurrence of cancer? And then you spin that out in your head, you keep going and going and going, making a full featured film about it, you're going to make yourself extremely anxious. But it's normal to think things like that. But it's the power you give them and your ability to detach from them. Okay. So another form of treatment is exposure treatment. Again, when people get into those avoidance symptoms with PTSD, sometimes they really get to a point where they can barely come into the clinic, or they stop treatment, or they don't do their radiation because they're so frightened. And so desensitization to those avoidance can happen through, usually we do that in the person's imagination. So you get them in a calm state and imagine doing the thing that they're so fearful of and they're avoiding, and then gradually work toward having them in that situation with lots of help and guidance. Okay, I already talked about mindfulness. Some other integrative treatments that we use are tapping, which is tapping can reduce the stress nervous system response by tapping on acupressure points. Not on here and similar is Reiki and healing touch. We do some hypnotherapy, can be helpful. EMDR is something called eye movement desensitization and reprocessing. Aromatherapy, journaling can be very helpful, and art therapy can be very helpful. I would be remiss if I didn't mention medications, because with PTSD, medications can be extremely helpful. SSRIs, SNRIs, and anxiety medications for sleep can be extremely helpful in the treatment of PTSD. And then just for you all, you can do the things that you can do too. It's extremely important to get plenty of sleep and rest. Exercises, we're finding a whole new honoring of exercise and treatment, minimizing caffeine, nicotine, alcohol, surrounding yourself with supportive people, and finding groups like this or support groups to go to as well. Also want to mention that caregivers, again, the observers of those who have the traumatic life-threatening event, and the rates can vary, but caregivers can experience PTSD as well. Okay, now that's PTSD. I'm going to talk a little bit about post-traumatic growth, because I see this happening with a lot of my patients. If what I talk about does not apply to you, please do not use that like, why aren't I experiencing growth? It's not a right or wrong thing, but trauma can also cause significant positive impacts in people's life. But it's also why I want you to empower yourselves by getting the help and or using the tools that you can to first and foremost decrease the likelihood of trauma, post-traumatic growth happening, but also maybe to facilitate growth that might happen. So post-traumatic growth describes a positive psychological change that is experienced as a result of adversity. Other changes happen, and it leads people to a higher level of functioning. So this adverse thing happens, changes occur, and there's growth as a result of those changes. For some patients during cancer and after cancer, that can happen. It is different than what's talked about as resilience. Resilience is when an adverse thing happens and then you return back to the normal. You have the resiliency to return back to normal functioning. Whereas this is taking a traumatic event and using it as a growth experience. There's overwhelming evidence that a lot of people facing a wide variety of difficult circumstances experience growth. And approximately 90% of people diagnosed with cancer overall, not just breast, have at least one aspect of post-traumatic growth, like a renewed appreciation for life or realigning of priorities. And then I just want to put this quote in by Jim Reardon, who's done a lot of research and writing about post-traumatic growth, that post-traumatic stress, that event, is a natural, normal process of adapting to adversity that can go one way and can be the beginning of a transformative journey, okay? Associated psychological factors with post-traumatic growth are younger age, longer time since diagnosis, greater cancer-related stress, and weirdly, you wouldn't think this, but an increased perception of greater cancer-related threat. Positive adapting, coping, talking about breast cancer, religious coping, and seeking social support are associated with associated psychological factors with post-traumatic growth. Post-traumatic growth can result in enhanced interpersonal relationships. Again, that increased appreciation for life that like you might have taken your life for granted, so to speak, and now there is this sense of vulnerability to death that can lead to that appreciation for life. A lot of people that I work with have changes in priorities and goals. They might say things like, that's it, I'm done with that career, I'm not gonna do it anymore. A lot of people have an increased sense of competence. People said, this was the biggest thing I feared. It's like people who have cancer in their family feared getting a diagnosis of cancer and will come out with, if I can do this, I feel like I can do pretty much anything. Some people will have new life experiences. Like since I had cancer, I thought, well, I've always wanted to do this, and now I am going to do it. Again, that sense of personal strength. I made it. I did this. I can't believe I went through the diagnosis, chemotherapy, surgery, radiation, chemotherapy, and I did all of that. There's this strength. Spiritual development can happen, and there can be sometimes this increased satisfaction with the meaning of life. Sometimes I hear people say, I get frustrated with people talking about stupid, trivial things. Those are some of that growth that can happen. Promoting, things that can help you experience growth are reducing anxiety, reflecting on your experiencing, and looking for benefits. One part of our mindfulness class that we do is teaching gratitude, which can promote post-traumatic growth. Restoring a sense of safety, that oftentimes happens, like you're very fearful, and then you get your treatment plan and you go, all right, this is all I'm going to do now. I'm just going to focus on this part of my experience. Doing those stress reduction things like mindfulness, meditation, and prayer. And remembering mindfulness is not some Buddhist concept. It is practiced a lot, especially in health conditions, as promoting health, healing, overall well-being, and decreasing the stress nervous system, which has a negative impact on our immune functioning. Trying, even though you might not feel like it, connecting with others. Again, your organization can sometimes help with that. Writing about feelings and emotions, creating a vision for goals during or after. That integrative essentials, part of what we have people imagine is, why do I want to do this? Well, I want to do it for this. Imagine that in great detail. When I get through it, what do I imagine myself doing? And just briefly, there are similarities and differences that they aren't significantly related to each other, PTSD and post-traumatic growth, but some not being able to talk about breast cancer, a perception of breast cancer as a traumatic event were associated with PTSD, younger age and perception of cancer as a traumatic event and stressor were associated with post-traumatic growth. So what I'm saying with that is your subjective appraisal in adjusting to cancer is really important, and that's something that you can influence and have power in. So the same experience can lead to two outcomes with no judgment. If you've had trauma, no judgment. If you've had growth, no judgment. But when you're facing mortality, it can be overwhelming and traumatic, and it can lead to unhealthy coping strategies, or it can also lead to you reflecting, redefining, realigning life's goals and priorities, which is captured by this quote, which I'll finish with. Viktor Frankl is one of my favorite people, who was interred in a concentration camp and wrote Man's Search for Meaning and other wonderful things. And what he says is, when we are no longer able to change a situation, we are challenged to change ourselves. In other words, you can't change the fact you've been diagnosed with breast cancer, but it does provide you an opportunity to challenge yourself, to change yourself, and help yourself in positive and growthful ways.
So if we were in a room together, I am 100% confident that you would be getting a standing ovation right this moment.
Oh, Eileen, you're so sweet. Thank you.
And so there were several comments that were coming through into the chat session. And actually, one of the early chats that came through, there were several accolades here, but I do have another. You gave us several, I think, very lovely quotes. And so I'm going to share one from the group, because you haven't heard this yet. So I want you to hear. A breast cancer survivor told me, I didn't know when I was going to die before I was diagnosed. And I still don't know when I'm going to die. I'm not going to waste the days that I have worrying about reoccurrence or the fear of death.
Yes, yes.
And so I think there's an affirmation there that goes along with some of the other quotes that you had shared with us this morning.
The only thing
I would say with that is that
But even if it pops in your brain, like, what if this is the time I go and have my scans and they tell me something different? The wasting of the day would be sitting in that. But it's okay to think that. It's normal to think that. Yeah. Wonderful.
I appreciate that you would share that part, because there is so I will say that I don't have any questions yet, and perhaps a little conversation might inspire a couple of additional thoughts. And I think part of that, this is really the first time that I can recall us doing a program where I haven't had a question to pose to you. And so as I was myself listening, and of course I had a sneak peek the other day with your slides, but I would like to kind of probe a little bit on the subjective appraisal.
Mm-hmm.
And you mentioned that towards the end of your talk, and that whole assessment of where people are at, you know, the emotional roller coaster that accompanies an initial, you know, diagnosis with, you know, I have this news to break to you, and et cetera. And then you kind of wave through the information and perhaps developing your treatment course and so forth. Can you give us a little insight as to how to get through that objective appraisal that we can all internalize today?
It's helpful to reflect on how you're thinking and how that's helping or not helping you. So for instance, and again, thinking is thinking, but alterable, not judged, but alterable. So for example, if somebody says to me, I never should have gotten cancer. I have exercised, I've never smoked, I don't have cancer in my family, I've eaten only organic, I meditate, I do yoga, I am the person, I did everything in my life where I should not have gotten cancer. Well, whenever you hear yourself shoulding yourself, you know there's trouble, because you did get cancer. So it's kind of like, I usually use examples that pop in my brain. So I, for a while in health psychology, I worked at a nursing home, and patients would say, I don't know why God is keeping me alive. I don't know why I'm ready to die. And I would say to them, I don't know why either, but you are alive. So what do you want to do now? What do you want to do with that? It really keeps you stuck thinking that you shouldn't have got it. And when you can move to a place of acceptance of what is, it provides great freedom, but it can be frightening. So I never should have gotten it keeps you from accepting the fact that you do have it. So it's a little bit of that denial that I often talk about a diagnosis of cancer as a grief process. So I should not have gotten it. This is ridiculous. This never should have happened. And it happened, right? And there might be anger associated with that as well. So when you get to a point of, I have breast cancer, now what do I do with that? It can be the most horrible, awful, terrible thing. And I can predict that I'm going to get sick with chemotherapy and I'm going to burn all up from radiation and probably have a reoccurrence. Those are experiences that are going to influence your course in a negative way. We know that. We know that imaging outcomes positively can positively impact. So when people go through surgery and we instruct them, coach them, and use hypnotic suggestions, that their body is going to begin to function exactly as it should. Their digestive system is going to be working exactly as it should. They do better with recovering from the anesthetic. When a lot of the new pain research is about altering that, the experience of pain that is mitigated by how we perceive that.
Thank you. That was really good. And actually, that conversation did inspire some questions. So let's go to a few things now. Is it good to label a possible PTSD diagnosis for your patient?
That is a really good question. Is it good to label anybody with anything? Might be the bigger question. In so much as that if they are really suffering and the symptoms are negatively impacting their course physically, mentally, and behaviorally, then whatever you label it, it doesn't matter. What matters is that you identify what's happening and you get them to places that they can get help. Okay, you have PTSD. It's not like in the service where if you have a 50% disability from PTSD because of time in Iraq, then you get money. It's nothing that's like that. And there are some people in my field who would argue labeling has a negative impact. So what I tell people is that whether you have a label or not, what matters to me is that these are the things going on, and you know you, and I know how I might be able to help you. And if we work together, that might promote positive change. Yeah.
So I'm just going to feed, and I know you're not reading the chat, but I have several affirmations coming in that you're articulating exactly how people are feeling. And so I'm just going to continue on. What modalities of therapy do you find the most helpful in working with patients with PTSD?
And I think I really do use a combination. I've been trained in EMDR. I've been trained in hypnosis. I've been trained in mindfulness, and I just try to meet people where they're at. Initially I do a lot of education with people, which I continue to be amazed at how empowering that is. How empowering it is to say to people, you've had something traumatic, where most people have some type of death thought go through their brain. And as a result, these are the things that happen. And teaching people really simple strategies, like if it's someone in the hospital. I work with all cancer patients because I work in Fargo, North Dakota, and I'm the psycho-oncologist here. And so I might work with a acute leukemic. So they went to the doctor after feeling kind of crummy for a week, and they're on their way home, and the urgent care calls them and says, you need to go to the emergency room right now. Don't stop, go. And then we have them in the hospital doing chemotherapy nearly within 24 hours, and their life is completely changed. Well, one of the first things I say to them is, this has happened and your body is reacting as a result of it. These are the things that happen when your body is under stress. And I'll teach them that little strategy. And the first thing I'll teach them is either breathing, or if they're having a hard time breathing, I stay away from the breathing, and teach them about mindfulness. You can do mindfulness of sound, where I say, close your eyes and tell me, see if you can pay attention to the sound there. And when your mind wanders into thinking, bring yourself back to the sound that you hear. I can teach people just basic relaxation strategies, 4-7-8 breathing, square breathing. And I tell like patient stories as if it was one patient, but it's usually like a conglomeration of patients. But there might be an occasion when I teach that basic thing when they're first admitted to the hospital and have a new diagnosis. And I'll say to them, I just want to teach you a couple of things that might be helpful to help you get to sleep tonight, or to do this tonight. Well, in some situations, they have had those really negative reactions to their initial chemotherapy, and they have anchored themselves in that breathing technique. You'll see if I am in a patient's hospital room, I'll have a square there, or 4-7-8 breathing, or the counterbalance thing, and they'll say, I just looked at your thing and went in 2, 3, 4, pause 2, 3, 4. I think I got away from the question, but I use a variety of modalities in the treatment of PTSD. And by the way, I didn't know if this quite got clear, but in the treatment of PTSD, there can be a lot of promotion of growth that occurs. Eileen, you went away.
Oh no, I will be right back. My battery's running low and I'm going to have to plug in somewhere else. But before I do, I'm going to ask the next question.
Okay.
If you are not always confident in your care team's approach, but have overall confidence in your care team, how would you suggest approaching them to let them know your concerns. And I'm going to say more concerns along the issue of mental development or, concerns and so forth, as opposed to addressing some of their physical treatment.
Yeah. Okay, so I'm an example giver, but I think if I have coached people to be honest and direct with their care team providers, whether it's the nurse, the mid-level, or the physician. So we've written it down. Doctor, I wanted to talk to you about this. And I mean, maybe it's like that the doctor keeps focusing, they've gone through treatment, but the doctor keeps focusing on their BMI and they got to lose weight, they got to lose weight. And they don't feel heard in their overall concerns and well-being, and feel judged maybe. Not that the doctor's intending that, but they feel judged by that, and then they don't want to go back and see them, and so then they drop out of care. Or some of my young patients will go to their physicians after treatment and say, I was thinking about maybe using birth control, and that's not always easy for an oncologist to talk about, right? But they're seeing their oncologist still as their pretty much regular doctor. So the best approach that I can recommend is to say something like, I need to talk to you about something, doctor. And it's hard for me to do this, so I wrote it down, but I really need to, whatever it is, okay? Practice it with people. Sometimes people like to write, I don't know if you all use my chart, or like, Dr. G, I wanted to talk to you today about this, and they'll write it down. So then they have the introduction already made. I don't know if I'm addressing it, and if that person has a specific example, that might help, but hopefully that helps. Directly talking to your treatment team. And there have been occasions where I have facilitated a change in a treatment team because it's been so interfering, but it doesn't sound like that was the case here.
I think you've given some great examples. There's a number more questions, so let's continue. Have you worked with brain spotting in people with PTSD? If you have, do you feel it is a good treatment option?
I have not, and I'm just going to own that I don't know even the research on brain spotting with PTSD. I'm sorry.
Okay. All right. So you had mentioned 4-7-8 breathing a couple of times, and there's a question. No one knows what it is.
Okay. So I was hoping that we might be able to practice one little aspect of things. 4-7-8 breathing is a lot of the breathing techniques we use and research now in mind-body medicine have been around for thousands of years. Little Andrea, my helper here, is a expert yoga instructor. So she's like, whatever. Andrew Wheel, MD, who does a lot of integrative care down in Arizona, kind of put 4-7-8 breathing up against anxiolytics like Valium, and said 4-7-8 breathing is like a tranquilizer for the brain if practiced regularly. And it's not that tough a skill to do. It's using deep abdominal breathing, which is breathing from the belly, maybe putting your hand over your belly button and try to breathe in deeply into your belly using your diaphragm. A lot of people, when I say take a deep breath, they'll go like this. And that is the opposite of that. That's the kind of breathing that you use when you're sprinting. And oftentimes going through breast cancer treatment is not a sprint. So you breathe in for the count of 4, then you pause, not hold your breath, for the count of 7, and then breathe out for the count of 8 through pursed lips, like, and trying to get all the air out. So I'll demonstrate it. It's a little hard for me to do it when I'm breathing and talking, but you breathe in, pause, 2, 3, 4, 5, 6, 7, out. So if everyone wants to do it, I'll just be the counter. So you're going to everybody exhale, then inhale. 1, 2, 3, 4, pause. 2, 3, 4, 5, 6, 7, out. 2, 3, 4, 5, 6, 7, 8. Let's do one more. In 2, 3, 4, pause, 2, 3, 4, 5, 6, 7, out, 2, 3, 4, 5, 6, 7, 8. He's put this up against anxiolytics, and 4 cycles, doing that 2 more times, twice a day, morning and evening, has been shown to have this calming, quieting effect on the sympathetic nervous system, which I didn't really talk about, but there is the acute treatment of the sympathetic nervous system, things that you do directly to impact the arousal of that stress nervous system. But then there are things you can do on a regular basis that decrease the arousability of it. So like we had a beautiful mindfulness class last time, and one of the kids sent a note in on the evaluation that said, for the first time in 3 years, I went to my scans and wasn't petrified because I've been practicing these long term. I still had some few what if flips through my brain. I still was a little bit anxious, but it didn't go over the edge so I could barely breathe.
Well, that's powerful right there.
Yeah.
I appreciate you sharing the breathing techniques, and I think that is something brand new because I was going to ask that question myself if it hadn't come up.
Square breathing
so,
is the same. You breathe in for 4, pause for 4, out for 4, pause for 4. And I have people close their eyes when they do that, because if you're hooked up to a biofeedback machine, you're deepening and lengthening your breath. So if you just use your imagination, you can increase the size of your square as you get better and better at deep breathing. Yeah.
Ah, okay.
Other
Okay, good tips. All right, so I'm looking for here. So we got some thank yous on that one. And so again, like you say, I'm trying to give you as much feedback as we possibly can so you get a sense of our wonderful group. And so here's one that I had skipped over before. I would say, I believe, fill in the blank, since I could not have a negative and positive thought coexisting. I choose positive to keep myself in a better mindset. And so I think that is more of a statement, not necessarily a question for you. Okay, that came in.
I can't tell you how you patients have influenced me, but sometimes I used to talk more about positive versus negative, and now I talk about neutrality, because patients don't always like to hear, you got to be positive, you got to be positive, because sometimes they don't feel like being positive. Sometimes when you got diarrhea and you can't get out of bed and your feet are numb, you don't feel positive. But you can move to this neutral place of non-judgmentalness, and it is what it is right now. And what might I try to do to tolerate this moment in time? Yeah.
I'm sort of envisioning people going in for treatment, and everyone will be practicing their breathing techniques.
Yes.
I'm kind of getting a little bit of a sense of that right now.
If I had my druthers, everybody would sit down in the waiting room or in the infusion room, and up would come a screen, and they would pick which breathing technique or imagery or relaxation they want to involve themselves in today.
I think there's probably some of that. So I'm just going to check over on the Q&A side, because most of the questions have been coming in through the chat. And so I think we have gone through all of those questions at this particular point, which were some really excellent ones. And so I think I think we're done with all of today's questions that had come through. And so I so much want to thank you, Dr. Hysjulien. This was illuminating on a number of different levels. And I'm hoping that for our audience, that people have some tools. There's the tools in the toolbox kind of a metaphor here, but I think it does make sense. And I think you mentioned in a couple of your slides where you really speak to people's engagement with their medical team and keeping that positive. And as I have heard with our support services program manager, and I'm going to introduce her in a moment. That's Damila, and you have actually met her virtually in the past. that we all come into this world from a different perspective. And
Right.
so it's moving people forward in the most positive and engaging way, and kind of using what is in our inner reserve and harnessing that going forward. I think that's a lot of what we heard.
Yeah.
And so do you have, before I introduce Damila, do you have anything else you'd like to add to say to the group?
No, I think that one of your next speakers, or one of the speakers coming up, talks about integrative things. But I do want,
Yes.
I do want to just put a plug in for when I started practicing this, I used little CDs and tapes. But now you can go to apps on your phone and YouTube and practice mindfulness, practice loving kindness and compassion. And you will be inundated with things. Insight Timer is one of the ones we have people use. Calm, but there are lots of things that you can start doing today. Well, you already did start doing, because you started doing 4-7-8 breathing. So I would just, I feel like there are so many things that you all have taught me, but first and foremost, you've taught me that to listen to you, which is what I try to do, and then grow that in my practice with others of you. So I thank you for inviting me to be part of this today. Thank you.
Well, thank you, thank you, thank you. And so if you want to stay around for a moment, or you can jump off. I do want to introduce, and first off, I want to say thank you for the Two Life team that works behind the scenes to both do the research and prepare for the programming that we're offering this fall and winter. And so, so with me today is Damila Hills, and Damila Hills is our support services program manager. She is newer to Two Life. And so she has, I think, a very interesting background that is very, I'd say, very adaptable to some of the issues that were brought up today. So Damila, why don't you introduce yourself? Tell us about you.
Hi, good morning, everyone. Eileen, thank you so much for that introduction. My name is Damila. I'm the new support services program manager here at Two Life, about a month in. And Cheryl, I enjoyed your speech so much, and it really made me reflect on my role as a crisis counselor for the Department of Mental Hygiene, where I work with individuals every day who call in with traumatic experiences that they've endured, either through the pandemic or matters that were, pre-pandemic, and just giving them those tools and letting them know that it is okay to kind of be in that moment. It's okay to be upset, but it's worthy to continue to fight, to continue to move forward and gain back your power and gain back, your life. Just hearing your story and hearing what you said just really made me look at my role and what I do to kind of help individuals who are going through trauma. And I'm just absolutely ecstatic about my new role in being able to reach out to these phenomenal women who are going through such a brave battle, and just reminding them that their lives are they have so much worth and meaning. And, they need to continue to go through this fight and be strong. And I commend all of you women who are on here, because you're all phenomenal women. You're all strong. And, I really just admire and respect the fact that you all have the willingness to continue and be positive and say that I'm going to live and I'm going to get through this and I'm going to survive. And I really commend all of you.
Thanks, Damila. So with that, thank you, everyone, for joining us. Have a great day. Thank you, Dr. Hysjulien from North Dakota, and we'll speak to you in December. Happy Thanksgiving. Bye now.